Welcome everybody to the next part and gift of hormones in the gut. I did want to make a mention of thyroid because I'm mostly talking about the unappreciated role of sex steroid hormones in the gut and a little bit about oxytocin, although we have an entire class on oxytocin the next time we have a pro meeting on the clinical practices, the dosing, etc. And also some of the ins and outs because it's become so expensive in the pandemic. Most people don't think of hormones in the gut. And one of the important hormones that we often don't think of is thyroid. The two major hormones that have a lot to do with transit time in the gut are thyroid and oxytocin. Both of them signal the gut wall and maintain proper contraction. For example, oxytocin really is powerful in gastric contraction. So insufficient oxytocin is often something for you to consider with gastroparesis. But I had a patient that I wanted to go over a major case report. He's a practitioner and he's had constipation all of his life. And he now is having some cognitive decline and lots of esophageal issues. He has a disturbed Z-line, which is often where Barrett's cellular changes start. He's been tracked for thyroid all of his adult life. He's 70 years old now, and no one has put him on thyroid. But when we were going over his intake, and I saw him a number of months ago initially, he reported to me that he's been cold all of his life. No matter what he does, he's freezing cold, which of course is a classic sign of insufficient thyroid. He runs a kind of low free T3. His free T3 has been 2.5, 2.9, but no one has ever put him on it. He's seen a functional medicine doctor, he's seen naturopathic doctors, and no one has felt that, they all felt that his TSH was healthy enough and his T3 wasn't poor enough. They tried him, I think, maybe for 1 month on Armour Thyroid and nothing happened. Now, I don't know if you remember, but Medscape is an extremely conservative journal, and it's supported mostly by pharmaceutical companies. And in the last year or two, they've come out with a number of articles saying, let's face it, thyroid blood parameters really don't accurately reflect what's going on in the periphery. So they had an article in particular on infertility, and they said, if you have an infertile woman who's failed IVF and a number of things and her thyroid looks normal to you on blood, just go ahead and put her on thyroid replacement and see if she gets pregnant, because 25% of those women most likely will get pregnant because there is an entity called subclinical hypothyroid that is not picked up by TSH, free T3 and free T4, and they included free T3 and free T4. So they said, we now know beyond a doubt that our basic panel for thyroid doesn't really tell us everything that thyroid is doing in the periphery, which includes the gut. So his free T3 hung out, as I said, between 2.5 and 2.9. And Kent Holtorf has discussed that the TSH receptors for thyroid are completely different than the periphery. So he doesn't even run TSH anymore. And one of the doctors I practiced with in Naples doesn't regard TSH when she decides whether a patient is hypothyroid at all. She only looks at T3. So we decided he didn't have thinning of the last third of his eyebrows. He didn't have brittle nails. He does have a little bit of dry skin, but not that bad. He's got a little bit of cracks and dry skin on his heels. The biggest deal is he's been cold his whole life. He said, my whole life I'm cold. If I could do something not to get cold, and I went on Armour for a month and it didn't do anything. It didn't warm me up at all. And he has this chronic constipation. And he's been constipated no matter what he does, and everything that he tries works for a week or two, and then it doesn't have sustained benefit. So what we did was put him on a sustained release T3. We usually start out really low no matter what, because T3 is very fast acting and can hit the heart really quickly. So you really, even if a person comes back with really low free T3, you want to start with a very slow and low amount of T3, and you always want it to be sustained release, because sustained release T3 hits the heart much more gently than Cytomel, the commercial T3. That's one of the issues with Cytomel, is that it hits the heart so quickly. when you do put someone on thyroid replacement, you usually have to wait 6 weeks to follow up to see whether whatever you recommended improves them, but not with T3. Because T3 is such a fast acting player, you can start to have a patient that, well, if you don't like how you're feeling in 3 or 4 days, then add another 5 micrograms before lunch. And then in another 3 days, if you're still not feeling better. So we did this with him. We encouraged him to self-titrate to a point where he had a little bit of looser stool, a little bit more easy time with having a bowel movement, if that happened. And he also got warmer. And when he finally got up to 20 micrograms, 10 in the morning and 10 in the afternoon of T3, he started going to the bathroom and he started being warm for the first time in 70 years. And that is really a sign, a suggestion of insufficient thyroid, because your thyroid has a lot to do with your circulation. And remember, it oversees contraction, especially in the colon. And oxytocin and thyroid are the 2 major players, and they're team players. So because he has very severe esophageal disruption, he has belching all day long. He has esophagitis, and he's of course concerned that he might develop Barrett's. So we're going to recommend one of the things we're going to talk more about in the oxytocin module, which is oxytocin and Mucilox, and a number of other things for improving esophageal function. But we needed to make sure that the thyroid was healthy, because oxytocin is a hormonal team player. And it needs to have a right amount of estrogen and a right amount of thyroid on board for it to signal optimally. And you'll hear more about that when we go into it. But one of the reasons I also wanted to work on seeing if he could benefit from thyroid replacement was if he would then benefit from the oxytocin replacement that we gave him for his esophagus. He also tended to have very low, he did a Dutch test, he had already brought it in with me that his functional doctor had run, and his estradiol and his estrone were extremely low. And men need estrogen too, and oxytocin needs estrogen as a team player. So I added a few milligrams of estriol and he was very low in progesterone, a few milligrams of progesterone in a Versa anhydrous base to be applied after he shaved, because Versa anhydrous, if you remember, helps absorption tremendously in a topical application. And men have thicker skin because they have more testosterone. His testosterone without any replacement was way on the high end. His total testosterone was almost 800 with no replacement, because he lives so well and exercises and eats well, but he still couldn't, no matter how much fiber he ate, he couldn't go to the bathroom. And his gastroenterologist just kept giving him different types of fiber, but none of that worked. And he kept trying magnesium, going higher doses of magnesium, and that would work for a day or two. And then he would get these little pellets again, or go several days without going to the bathroom. So when we got a little estriol and progesterone as a facial cream and a base of Versa anhydrous, and we got him to the point of 20 micrograms. And I gave him a base of 25 milligrams of Synthroid just to give him a little T4. So often when I'm starting to work with T3, I'll give a real low base of just to have some T4 on hand. And within 3 weeks, he was warm and he was going to the bathroom. So it's always something for you to think about, is when someone has a chronic case, a history of constipation, think about the 2 major contractile hormones. That's what oxytocin does during pregnancy. It contracts the uterus. But we also have oxytocin. They're not exactly oxytocin-like receptors, but they signal receptors that line the entire gut. You have oxytocin receptors that line completely your esophagus, your stomach, your large intestine, your pancreas, your liver, and not your gallbladder. Because your gallbladder is a storage organ, so there's no oxytocin receptors there. All your islet cells, your alpha and beta islet of Langerhans cells, all have, in fact, the beta cells, I think, have 100%, and the alpha cells have like 96% receptors for oxytocin. So that oxytocin is a major player in the gut. And often you only need to give oxytocin when you give it for a few months, and then the body starts kicking in, making its own. Not always, but often oxytocin replacement is a jumpstart replacement. You don't have to keep it up. And unfortunately, the price in the pandemic has gone up. So we're lucky that in Naples, Florida, one of the pharmacist that loves getting all of our business, he's decided to carry oxytocin just a little bit above cost to help our patients out because it's so expensive, and he makes so much money on all the other hormones. So you can sometimes work with some of your compounding pharmacists to see if they'll give you a better price on a hormone if you give them so much other business for your other hormones. So I wanted to give that really fascinating case report. This is someone who's 70 years old, doesn't remember ever not having problems with constipation. And, he came in really for this esophageal problem. But if you have chronic constipation, it's very difficult to treat the esophagus because you have gases building up in the lower bowel and then they rise upward. The other thing that was interesting is he was working with a functional medical doctor who had recommended he try digestive enzymes. And just as an aside, there was some stomach acid, betaine hydrochloride, and there was also pepsin. Of course, most stomach acid, the industry standard is to have a little pepsin. Now, someone who belches all the time, and he even said, sometimes if I lie down and take a nap right after I eat, in a half hour, what I ate a half hour ago will be right in my mouth. So he had a lot of reflux. So you have two muscles. You have your lower esophageal sphincter and your upper esophageal sphincter. And when they're wearing out, you have a lot of gases flowing upward. Well, pepsin aerosolizes upward and is very damaging to the cells of the esophagus. So in anyone with any esophageal disorders, you never want to give a digestive enzyme with pepsin. I don't even use pepsin anymore. We've discovered with some forward-thinking ear, nose, and throat doctors in the last few years that pepsin has this quality. It can even aerosolize into your ears or into your lungs and create asthma or pulmonary issues from reflux, and it's partially due to the pepsin. So contraindication is giving digestive enzymes with pepsin to somebody with esophageal disorders. And there's only been one study ever that has measured synergy and efficacious combination of pepsin along with betaine hydrochloride, and they never found that betaine worked any better with giving pepsin. It just was an old thing that people had done since the 1940s. If you give stomach acid, add some pepsin. So it's become an industry standard. And there's only very few companies now that make stomach acid without it. Douglas Labs has one. They have a betaine hydrochloride that only has betaine hydrochloride, and then they have betaine hydrochloride plus, and the plus stands for the pepsin. Premier, and that's 648 milligrams of betaine hydrochloride. Premier Labs has 500 milligrams if you want to inch a little slower. He said, let's inch a little slower because I'm fearful that the acid will go up and harm my esophagus even more when we were doing this self-challenge of acid, which I'm going to go over in the live group this week, how you do a really good self-challenge with stomach acid. But so I recommended we go with the lower dose from Premier Lab. But I thought you might be interested in hearing this. That's kind of a lot of good information. So just because someone has tried Armour Thyroid doesn't mean that you've really given thyroid a try. There's a very small amount of T3 in there. And sometimes you need to really up T3. We have some patients on T3, 100, 125 micrograms of it, but it's rare. But you always want to start with only 5 micrograms because it can hit the heart. And if the person gets irregular heartbeat or rapid heartbeat, you don't want to put them in AFib. One of the common causes of adverse complications of T3 is AFib. So most of the time people are going to need more, but you want to start no matter what. Even if they came back with a 1 on a free T3, you'd still want to inch in. That's my opinion, just because you want to be careful with how it hits the heart, especially with somebody in their 70s, because people can just develop AFib spontaneously. So I hope that that was an interesting case report. We're going to go now to the next slide, if it will do it. So we were talking, and I'm going to get rid of these pictures here. There we go. I want me talking. Where did I go? Okay, there we go. And I'm going to drag this down here. So we were talking a little bit about the integrity of the gut wall. And as you have a higher zonulin on a comprehensive stool test, one of the ways you help bring zonulin down, remember zonulin was discovered by Fasano, who was the forward-thinking pediatric gastroenterologist that first really put celiac disease and gluten issues on the map. And he discovered that an adverse protein, zonulin, would attack adhesive proteins between enterocytes, and zonulin is one of the major causes of leaky gut. So when you see a zonulin on an elevated zonulin, on a GI map, it's above 107, but I feel like someone's starting to get a leaky gut if it's over 80. And when zonulin is elevated, you want to give zinc carnosine, because zinc carnosine helps to hold together the enterocytes. You also want to take a look at estriol replacement and progesterone replacement, because there's 4 basic adhesive proteins that hold enterocytes together. And estriol, estradiol, and progesterone upregulate many of those, and there's subtypes. So there's, I think occludin has maybe 14 different subtypes. Estradiol, E2, estriol, E3, progesterone, they all upregulate adhesive proteins. So you want to take a look at sex steroids, even in gents, as I was doing with this gentleman. And sometimes I'll give maybe a 0.5 milligram of estriol and 4 or 5 milligrams of progesterone. So a very small amount, but in that versa anhydrous. But another way to balance out and lower zonulin is to increase Akkermansia muciniphila. And Akkermansia muciniphila was kind of put on the map with COVID, because people who have more Akkermansia muciniphila in their gut tend to have less severe cases of COVID. It's protective against COVID because it's a marker of a healthy, diverse bowel. And that's one of the reasons it's such a healthy marker, that as you increase it in the gut, you lower anything that's damaging to the gut, like zonulin. So what boosts Akkermansia muciniphila? Estrogen boosts Akkermansia muciniphila, also eating a diverse diet, but intermittent fasting, there's quite a number of papers on intermittent fasting. Waiting several hours between a meal without snacking. Snacking really blocks the motor migrating complex that goes through about 2 hours after you eat a meal, and you've got housekeeping to clean everything out from the debris of the meal. You want the motor migrating complex to work. If someone's snacking all the time, it's turned off. And the motor migrating complex has a lot to do with healthy transit time and healthy gut wall. So we have an ill planet, which is threatening our hormonal signals and the tissues that contain receptors, which includes the gut. So part of our exposure to endocrine disruptors is there's so many actions, for example, with adhesive proteins that pull our enterocytes together when your gut wall should close. If a lot of pollutants come in, I was just handed, when I got my nails done the other day, my girl that I get my nails done from, she said, "Oh, here's a new green hand lotion. You good customer. I give you this hand lotion." And it says green tea on it and all these things, but it had many of those plastics that we discussed in the plastic webinar that we gave, and also in the EDC webinar that we gave. So it just looked like it was great. It had green tea leaves on the cover. It had a very sophisticated marketing package, but it actually it had plasticizers in it that would block estrogens, that could block upregulation of adhesive proteins that could contribute to leaky gut. So don't forget that when you're thinking of using hormones to protect the gut, you also want to avoid endocrine disruptors that could attack the gut. For example, bisphenol A blocks the normal release of estrogen. So if you're trying to give someone estrogen, even estrogen replacement, if they've got a fair amount of bisphenol A coming into their body, they might not be using it. This is a study that showed that bisphenol A blocks estrogen response in lung development, but we know by can alter the release of estrogen in target tissues throughout adulthood. This was a sentence that came out of this article called "Bisphenol A induces a specific type of signaling that can lead to cell arrest and aging, senescence, autophagy issues, stress response." And this was all based in the lung, but we now know that bisphenol A can block the release of signals to fetal tissue and to tissue all throughout the gut life. So as we get more plastics in us, even from sea salt, from fish flesh, from perfumes, then we have the blocking and the use of estrogens, which we now see protect the esophageal lining, protect the gut wall. So we know that heavy metals can displace estrogen. It's always good on every single patient when you're looking at their gut. You have someone that comes in with irritable bowel, inflammatory bowel disease, you want to know what their heavy metals are doing, because heavy metals displace hormones. And now we're learning that hormones are so gut protective. So in this one study, they show this one study showed cadmium-induced changes in epithelial cells of the rat's stomach. So the first thing that cadmium does is it reduces the population of parietal cells, and it blocks stomach acid release. So it's interesting, cadmium is known to be a heavy metal that's very associated with an increased incidence of risk of breast cancer. And in Dartmouth, there's a lot of cadmium in the soil, so they have a very high incidence of breast cancer in the Dartmouth area. And there's a high incidence of breast cancer in Long Island, and they've been checking through cadmium. There were a number of pesticides used on the old potato farms there. Well, cadmium, first of all, it reduces mucus thickness, which is where your immune system lives. It reduces stomach acid secretion, which is what we all need for so many multiple things, which I'll be going over in the live talk. It displaces estrogen and creates gut wall damage. And remember, estrogen is very important with parietal cell function and that gastrohepatic axis. So you always want to run heavy metals in the blood, and then either hair analysis or urine provocation. Blood levels tell you present exposure, and then hair analysis or urine provocation tell you past exposure. So when all of my Florida patients, they all consume a lot of fish. So I've been running serum levels of cadmium, mercury, lead, and arsenic, and they're coming back elevated in most of those metals. That explains why many of them have tried hormone replacement and it didn't quite work, because you take the hormone in, but the cadmium is present in their body and it keeps displacing the sex steroid. So cadmium will store in bone and fat, but there's a small amount, 5% of each fat cell is in constant circulation with the bloodstream at any one time. So being exposed to these things or having high levels of these things is a big issue. Now, in that one patient that I just was telling you about with constipation, he had a little bit of a mercury problem, which he worked with a doctor and got rid of it. So he had no heavy metals at all. So that wasn't part of his issue. But I think on everyone with gut issues, you should run blood levels of metals and you should run some historic levels of metals. Also, during pregnancy, many women experience a remission of autoimmune diseases. It could be multiple sclerosis or inflammatory bowel disease or uveitis. And the two major pregnancy hormones, of course, estriol will flush through a pregnant woman's body more than at any other time of her life. That's estriol is the anti-cancer, especially anti-breast cancer hormone. And that's why there's studies from the government. I talk about this in Safe Hormones, Smart Women, where they tracked some women and their levels of estriol during pregnancy, and they tracked them for 40 years. And the women with the highest level of estriol in the third trimester had the least amount of breast cancer throughout their life. And estriol signals that ER beta, the second estrogen receptor, or that Yanaki Gustafson discovered, the anti-cancer receptor. So estriol is the highest estrogen in pregnancy, and that's why women who get pregnant before the age of 18. There's never been a documented case of any woman who's gotten pregnant before the age of 18 having breast cancer as she grows up, because the estriol protects her breast for the rest of her life. And the more multiple numbers of pregnancies that you go through, the more estriol you're exposed to. And that's why multiple pregnancies are so protective against breast cancer. Although the first year after pregnancy, there's a slight increased risk. And then throughout the rest of your life, there's a statistically significant decreased risk. But of course, there's also progesterone. We know that women who get breast cancer surgery during the luteal phase, or if they have higher serum levels above 4 and 5 of progesterone when they go into surgery, they have much better outcomes. We know that progesterone is breast protective, and it's also progest, pro to support gestation, pregnancy. So both of these are very, very helpful. So they observed that women exposed to these hormones during pregnancy have less autoimmune disease. And that's where they first discovered that these two hormones help upregulate leaky, the adhesive proteins. And they started giving estriol and a little bit of progesterone to people with MS. That was the first pilot trials done. They haven't extended it to other autoimmune diseases, but I give more estriol and progesterone and also testosterone to inflammatory bowel disease patients, even in their 20s, because I want to get that gut wall with those adhesive proteins really working well. So estriol is the main estrogen in pregnancy, but it's received a lot less attention. It's known that pregnancy has an immunosuppressive effect because the autoimmune disease is your immune system on overdrive. So because you have a reduced incidence by the 3rd trimester of pregnancy, it suppresses that overdrive. It's not that it makes the immune system not work, it makes an overactive immune system work a bit more normal. So they've seen that this has been beneficial on multiple levels of autoimmune diseases like psoriasis, thyroiditis, rheumatoid arthritis. So these are the patients. There's 159 types of autoimmune diseases. You want to think of giving estriol to any of these cases because it upregulates the adhesive proteins and helps address that leaky gut. So there's lots of emerging data that estriol has potential immunomodulatory benefits for many immune system diseases. Autoimmune is only one of them. Inflammatory and neurodegenerative. We are seeing this throughout the literature, but it just isn't trickling down into the clinical trenches. So I now take a look at using estriol in both genders when I think that there's inflammation out of control. And this article was published in Menopause, Estriol Emerging Clinical Benefits. It came from Texas here, Texas Tech University in their endocrinology section. And so estriol is something to really consider with the gut, with helping leaky gut, but you can also expand that to many other illnesses and both genders. In fact, many articles say at the conclusion of the article on estriol, it's such a weak estrogen, you can easily give it to men. It's about the 7th of the potency to the ER alpha receptor. Most of its signal, about 5, 6, or whatever you want to say, 6/7 of its signal goes to the ER beta receptor, and that more often has an anti-inflammatory and neuroprotective and immune protective effect. So the conclusion of this article was estriol appears to offer a potentially cost-effective approach to a variety of conditions and a wide range of health benefits. So one, we're looking at it more and more for gut issues, but you can also be expansive with that for other issues. This is an article, this is still the same article. They reviewed the medical literature. 72 articles were reviewed, and they said the immunomodulatory role of estriol in reducing pro-inflammatory cytokines may be an important new therapeutic option for chronic autoimmune and neurodegenerative and gut diseases. This is the words of these authors. We conclude transvaginal estriol potentially offers, they were giving it in the women vaginally, a suitable physiologic delivery and cost-effective alternative. Since it is a relatively weak estrogen, there's a potential use for it in men with MS. So it's one of my major tools for so many different things. One of the intakes I run is an interleukin 6. If interleukin 6 is elevated or C-reactive protein is elevated, I then think of giving estriol replacement. Here's the first pilot trial where they took 10 pregnant women with MS and they gave estriol. There were pretty remarkable results. There was, just by giving estriol, there was an 80% drop in the white inflammatory lesions visualized on an MRI, which is the hallmark of estriol, and it protects hippocampal pathology too. So if a breast cancer patient doesn't feel good with being given estradiol, she still is of the and her doctors are of the thought that estradiol is contraindicated, you can give someone estriol to protect their brain. It protects where your memories are consolidated, the hippocampus. It mainly works through ER beta, but it does work a little bit through ER alpha to also reduce inflammation. But where it really shines is it upregulates one of these adhesive proteins. It upregulates occludin and it upregulates junctional adhesive molecule A. So estriol is a big way to treat leaky gut. You get an elevated zonulin on a GI map or a Genova comprehensive stool test. You want to think of estriol replacement, a man a facial cream and a woman as a topical or a vaginal cream. So ER beta, which estriol signals, repairs broken DNA fragments, which is great for cancer patients. It represses oncogenes, which is great for cancer patients. It tightens gut permeability by upregulating adhesive proteins, which is great for all gut patients. And most likely, there are going to be an expanding number of diseases that are related to leaky gut, because if you have leaky gut, you get all kinds of bacterial translocation of things that shouldn't get into the bloodstream. And I'm sure that that affects Alzheimer's patients, and it'll be a growing list of patients that are linked to gut dysregulation as the role of gut in overall health is more appreciated. The data suggests that ER beta may be considered a dominant negative regulator of ER alpha. So whenever you want to give any kind of ER estradiol to a breast cancer patient, you always want to make sure you give ER beta. And there's some people on the lecture circuit that say you never need to give estriol, you only need to give estradiol. Well, this sentence right here would really say we don't believe that, because the data suggests that ER beta should be considered a dominant negative regulator. It keeps ER alpha in control. So we know that the balance between ER beta and ER alpha in local tissues has a lot to do with keeping all of the estrogens working optimally. So if you want to give an breast cancer or hormonal cancer estrogen, the first thing you want to do is estriol, and then you would add the others, because it's the ratio of the receptors to each other within a tissue. It shouldn't be a cell, within a tissue, that determine the cell sensitivity to estrogens and the biological response. It's not the ligand as much as the multiplicity of receptors, which determines the plethora of estrogen actions. So, you come and you ask a patient, how's your testosterone, how's your estrogen? They go, I was tested, it's perfect. But we now know that the levels tested are just part of the whole story. It's also the receptors, the receptor functionality. And when I give my talk on my new receptor detox product and hormone balance and protect, which I'm going to do soon, because we all really need to go ahead and start going on them, because they really help these receptors work. And where the rubber meets the road with hormones is receptors. If a patient comes in and says that they have a history of a lot of polyps, you only have polyps as you start having less ER beta signaling. In fact, the more and more loss of ER beta signaling, the worse your risk of colorectal cancer. Colorectal cancer occurs when there is complete loss of ER beta signaling. So ER beta signaling, which comes from estriol or also food items, soy isoflavones, which are great for the gut wall, milk thistle, flaxseed, red clover, but the biggest food source that signals ER beta is soy. And ER beta prevents polyps. The more polyps that you have in your colonoscopy history, then you need ER beta. You have someone come in with familial polyposis, where they have multiple polyps. The way to treat them is with fairly aggressive amounts of estriol, and methylfolate. So the two most important things to prevent abnormal growth in the gut wall is estriol or ER beta signaling and proper methylation. And when they've done tissue biopsies of the areas right around polyps or in polyps themselves, they are devoid of methylated tissue, and they are devoid of ER beta receptors. So colorectal cancer is the leading cause of death, and we mainly get it when we have a silencing of ER beta. So in all of our gut patients, people with a family history of colorectal cancer, people with a lot of polyps, you want to take a look at estriol, and hormone balance and protect has multiple ER beta herbal signalers in it. I guess I didn't spell signalers properly, but estrogen receptor beta is an amazing target. The more it's signaled, the less colorectal cancer you have. And this article talked about it, ulcerative colitis, from inflammation to cancer, the estrogen receptors have a role. And you don't hear, gynecologists certainly don't talk about this, and nor do gastroenterologists. So all this phenomenal research doesn't really get translated into the clinical trenches. Whoops. What happened? I must have clicked on something else there. Okay. This was 48 patients affected by long-standing pancolitis were investigated. Samples were divided into 4 groups. This was ulcerative colitis, low-grade dysplasia, and colitis associated, high-grade dysplasia, and colitis associated cancer, and normal colon samples were used as a control. And what they found is ER beta fall could be considered a biomarker of ulcerative colitis dysplasia progression. So, and then in cancer, there was no ER beta signaling at all. So the article says it all: the sharp decline of beta estrogen receptor expression in long-lasting ulcerative colitis associated carcinoma. So I had a patient with long-standing pancolitis. She also had diabetes insipidus. She was on about 11 or 12 meds. She'd had ulcerative colitis in the beginning, and she was treated surgically. She had like 22 diarrhea bowel movements a day. And then after the surgery, she had 8. She still couldn't go out of the house and work very much. And she just had this long-lasting pancolitis. So I put her on estriol, low-dose naltrexone. I put her on a lot of soy foods and very minimal things because she couldn't really digest too many things. Within 1 month, she reduced on her own most of her meds, and with 2 months, her diabetes insipidus went away, and she'd been sustained on hydrocortisone by her endocrinologist for quite a number of years, and she was able to get off that. So I'm telling you this, and this woman was only like 40, 41, still menstruating. You don't think of using estriol unless it's an older person. Well, I've been using it for these different conditions, and the response is rapid, but you want to mix it with low-dose naltrexone. You always want to mix it with that because that's a global anti-inflammatory agent. Here's another article. I don't know where there's my, with estriol protecting myelin. It helps remyelinate nerves. It helps remyelinate nerves. And also they discovered that testosterone also worked synergistically with estriol in protecting neurons and stimulated myelin formation. You never hear about testosterone stimulating myelin formation. So these are things, these are hormones to think of in MS. And when you often give these hormones to protect the brain and the nerves, you often help clear up a lot of digestive issues. So where else do you hear that testosterone stimulates myelin formation? It's just incredible what you can find. And this is called Testosterone and Estrogen and Multiple Sclerosis from Pathophysiology to Therapeutics, using these for therapeutics. Pregnant women with ulcerative colitis show frequently low estriol values in both serum and urine. This was 18 patients with ulcerative colitis, 4 with Crohn's, and 3 patients with a bypass. And they found that the patients who had really severe gut didn't make that huge spurt of estriol like a typical pregnant person does. Low estriol concentrations were seen only in the patients, especially with ulcerative colitis, and especially if an operation had been formed. Somebody comes in and they have a history of an operation for inflammatory bowel disease, you're going to really want to take a look and consider estriol. In one patient with severe diarrhea, the estriol concentration in serum was low until the intestinal function normalized. As soon as the intestinal function normalized, the estriol concentration went up exactly when the diarrhea stopped. Now, we don't know if it's the chicken or the egg, but you got somebody with inflammatory bowel disease and severe diarrhea. That's what I've seen now in my patients. That's what I saw in that pancolitis patient. You give estriol and people with chronic diarrhea tend to improve. It's interesting, in this study, they showed that the estriol, the lower the estriol, the more the fetal stress. So the maternal serum unconjugated estriol reflected fetal-placental function. And what they found was as estriol was lower, cortisol levels went higher in the fetus. So you need estriol, it reduces cortisol. And if you have a lot of gut issues, that can then lead to higher cortisol in the baby, and that's stressful for the baby. Diabetic pregnancies do not differ radically from normally, but the stressed gestations have lower estriol and elevated fetal cortisol levels. So I thought that was extremely interesting. I'm not going to go over this one right now. I'm going to, don't want to go there right now. Okay. So here's some articles that you might get a chance to take a look at about estrogen, ER beta. And women are always saying, you know, they're always talking about estrogen dominance, and it's bad. Women come in and go, I have estrogen dominance. It's like an identifier. I'm a woman with I have PCOS and I'm estrogen dominant. But there's a good estrogen dominance now that we would know and appreciate, and that's ER beta. We want to have it. And I said this to Yanaki, who discovered ER beta. I said, I'm calling ER beta the good estrogen dominance. And he said in his Swedish accent, I wish I would have thought of that myself. And I think I've told you that already, but they also feel that ER beta exerts anti-tumorigenic effects in the colon. So if you've got a patient with colorectal cancer or a history of colorectal cancer, then you're going to want to consider estriol, which of course boosts ER beta. Barzi was a very, very interesting gentleman, and he was the guy that looked at colorectal cancer has a higher incidence rate in men than women. And we've all known this because women have more estrogen, and estradiol is very protective against colorectal cancer. But he was saying it's not just estradiol, it's really also ER beta. So hormone replacement therapy should always include estriol, which is a signaler of ER beta, because lots of women get put on the estradiol patch. Doesn't mean it's not a good thing to do, but then you want to add some estriol to it. And now we understand why, because that's going to protect a gut lining as that person ages. And of course, soy is the unique isoflavone that upregulates ER beta, which then protects the gut wall. So whoever thought of soy as being a food that protects the gut wall? But it is a I consume quite a bit of soy. Of course, I'm eating more of a vegan diet, and I need to have protein, and soy protein is equivalent to egg protein. It's a perfect protein. It has all the amino acids. So you can have roasted soy nuts, you could have soy pasta, you could have fermented soy, you could have fermented tofu, you can make tofu salad, you could have miso, but I try and get people comfortable with adding soy in a few times a week and explain to them that it's safe. And as long as you take iodine in the literature, I should have found that study and put it here. People often say, and Dr. Brownstein even says it, he feels soy is bad because he feels it harms the thyroid. Well, I haven't been able to substantiate that as long as you have enough iodine on board. So you either eat seafoods like kelp, or you take some iodine, and then that nullifies any potential adverse reaction of soy on the thyroid. But Barzi was the guy that said, let's take a look, in the Women's Health Initiative, the use of HRT in postmenopausal women reduced the risk of colon cancer by 56%. You got a woman or a man with a high incidence of colorectal cancer, you want to measure their estrogens. If a man is low in his estrogens, you want to give him a tiny bit in that facial cream. A recent meta-analysis showed that women who consumed a lot of soy, because soy signals that ER beta receptor, they had a reduction of colon cancer by 21%. And he said, we hypothesize that sometimes during the tumorigenic process, ER beta expression in colonocytes is lost, and the estrogen ligand, HRT, or soy products exerts its effect through preventing their loss. So part of pathology in the gut is loss of ER beta. You can reconstitute that with hormones and with some food process, and that's some of also the herbs that are in my product, Hormone Balance and Protect. Thus, in the adenoma, so that's just the growth out of control, but it's not yet dysplastic enough to be carcinogenic. So from in the adenoma to carcinoma continuum, timing of HRT is a significant determinant of the observed benefit. The earlier you start hormone replacement, the more you get protection of the colon throughout life. You get somebody that has a primary first degree relative with colorectal cancer, you want to start hormone replacement earlier. And also the protective effects are estrogen are due to ER beta, and also B6, magnesium, and folate are also important in the gut wall as protectors too. So colorectal cancer incidence is 35% lower in women than men. Autoimmunity is higher in women than men. So testosterone protects against autoimmunity. There are 159 autoimmune diseases, and men have less of all of them except one, the renal autoimmune diseases, but cancers are higher in women and lower in men. Did I get that right? Colorectal cancer is 35% lower in women than men. I think I got that a little turned around there. So in women, high parity, early age at first pregnancy, oral contraceptive use, and estrogen replacement therapy are each associated with decreased colorectal cancer. Birth control pills are related to protecting against a number of cancers because of their estrogenic role, like ovarian cancer, colorectal cancer, but they are linked to an increased incidence of breast cancer. Altogether, the data suggests that estrogens and/or progesterone protect against colorectal cancer. The other thing that's interesting about hormones is a new term that was coined and didn't quite take off and be sung from the rafters like we thought it would, but it was coined by Harvard researchers in 2013. It was published in Science, and the title of it was called Welcome to the Microgenderome. And in this study, what they discovered was that a young, and it was based on a mouse model, but it was extrapolated to the human man and woman, that early on, a young boy and girl, 6, 7, 8 years old, we have the same biome. But as we start making in menarche and in puberty, we start making hormones, our biome becomes genderized. And a woman has a more female biome and a man has a more male biome. So they call this the microgenderome. And I don't know if you've ever heard that term before, but a healthy microbiome produces more testosterone in a male biome that drives more immune protection, which is why men have less autoimmunity. And I thought that was really interesting. Interestingly enough, I'm trying to think of the name of that researcher. I can't think of his name, but Michael Baker has shown that a number of endocrine disrupting compounds and pesticides paralyze the ability of the biome to produce testosterone. And one of the new growing areas of research of endocrine disruptors is looking at how they disturb the microbiome production of hormones that protect immunity. So just in the way that Stephanie Seneff has taught us that glyphosate paralyzes the biome, some of the healthy bugs in the biome that make important constituents, we're learning that endocrine disruptors can block a healthy biome from producing testosterone and creating immunity, and that endocrine disruption, thus in that mechanism, might be one way that we're seeing a rise of autoimmune diseases. Certainly our government doesn't seem to be looking into this. There's called the unappreciated microbiome testosterone immunity link. While other endocrine disrupting compounds may interfere with enzymes that regulate testosterone concentrations, and some chemicals may act as androgen agonists and provide protection, but a healthy gut and no dysbiotic microbiome is part of the androgenic signaling that supports the 80% immune function in the gut. Now, depending on which articles you read, the gut wall is where most of our immune system lives. 70% to 80%. And a big part of the sustaining of that immune system is secretory IgA. And secretory IgA is supported by testosterone and androgenic signaling, partially that comes from the microbiome. If endocrine disruptors and bad processed food paralyze the microbiome, we start getting a thinner secretory IgA and less healthy immune functioning. That's one of the reasons that working out with weights and working out at the gym enhance secretory IgA, because they enhance testosterone, which enhances secretory IgA. So when you're reading a comprehensive stool test, and it says that the secretory IgA is below normal, giving testosterone replacement is part of the way that enhances it. Also to tell the person to exercise more, and to also make sure that they lower cortisol, because elevated cortisol can also thin it. I also found a very interesting article where chewing gum regularly thins out secretory IgA, because it just is a constant irritation. And I never knew that, but I just thought that was interesting. So a healthy gut will make androgens, unless it's paralyzed by endocrine disruptors, that help support the secretory IgA or the immune functionality of the gut wall. But when a gut gets dysbiotic, or we eat highly processed foods, or we're exposed to lots of plastics, microplastics that we're seeing in fecal material, this androgenic protection can be thwarted. This article is called "The Microbiome as a Target for Endocrine Disruptors. Novel Chemicals May Disrupt Androgen and Microbiome-Mediated Autoimmunity." So, a lot of gynecologists say you don't really need testosterone. Most of the women who come into me that have been put on hormones from a lot of other providers weren't recommended testosterone. And if they don't have a partner or they're older, they'll say, why do you want a libido? And why should you get a little bit horny? Or maybe your husband has erectile dysfunction and you don't want to have sex. And they only think of testosterone as giving a randy component to the benefit of replacement. But testosterone supports your gut wall immunity, and we don't think of it like that. It also is, what did we just see in that other article? It works with ER beta to protect myelination. Crazy. So it protects our nerves as we age. But what's the other major thing that I'm just going to make a mention here? It's not part of the topic. Testosterone has everything to do with shutting up ApoE4 gene, and it helps protect your hippocampus from atrophy and developing cognitive deficits. It also protects the cardiomyocyte. It's one of the major hormones, along with estradiol, that protect the health of the basic cell of the heart, the cardiomyocyte. So holy moly, you want testosterone on board. My best friend was saying, I just can't stand sitting in front of the mirror tweezing out all those hairs on my chin. That is one of the problems, is that you do grow chin hairs as you grow old, no matter what. But you do grow a little bit more when you're on androgen replacement. But the benefits are so huge. It makes your brain move at a faster pace. It maintains secretory IgA. It protects myelin sheaths. It works in so many protective manners that you don't want to leave home without your HRT maintaining testosterone. And it's also an anti-inflammatory. When do we think of testosterone as an anti-inflammatory? Which one makes it protective of the brain? So this article came from looking at multiple sclerosis. It's long been known that females are more susceptible than men to inflammatory diseases, including MS. And this also includes psoriasis patients. In addition, female patients with these diseases experience the improvement during pregnancy. But they found that both testosterone and estriol are anti-inflammatory and neuroprotective. So whenever I start working with estriol, I almost always now add testosterone. So this means many patients are getting MS and inflammatory bowel disease and psoriasis in their 20s and 30s. I take a look at what their free and total testosterone is. And if it's on the low side, I might give a very, very small amount, because it has all of these benefits from the gut to the brain. this is very interesting. They took a look at 65 patients who had some kind of gut surgery, from gastric to colorectal, mainly for cancer. And before they went into surgery, they measured their hormones. And after surgery, they measured their hormones. And then they tracked them for a period of time for complications. And what they found was the patients with the lowest level of testosterone were prone to higher postoperative complications in both men and women. So anyone that's going in for gut surgery, I am always, even if they're young, I am always measuring their testosterone or thinking of giving them a little testosterone before they go in, because it reduces complications after any kind of gut surgery. It's the same way before breast cancer surgery. I want to give progesterone a little bit before any breast cancer surgery to any woman, because you want that serum level of progesterone up, because her recurrence rates and her mortality rates and her survival rates and her quality of life will be better longer just from having progesterone levels higher when you go into surgery. There's like almost 30 articles that replicate that I wrote about in Safe Hormones, Smart Women. There's no debate about that. So a lot of times, depending on what a person is going into surgery for, I take a look at a little bit of hormone replacement to have them have a better outcome of that surgery. This is taking a look at non-obese diabetic mice, and the females, of course, have a higher incidence of diabetes. And then they took a look at the gut microbiota, and what they saw was that male mice who had more testosterone tended to have healthier microbiota that tended to protect against autoimmune disease. Type 1 diabetes, of course, is an autoimmune diabetes. So they said that our results favor a bidirectional model of gender bias in which hormones and microbes work together to trigger protective pathways. So remember this in your brain. Not only does testosterone protect the gut wall, not only does testosterone protect secretory IgA, not only does testosterone protect myelin, not only does testosterone protect volume of the hippocampus and tamp down Alzheimer vulnerability genes, androgens protect microbiota that protect against autoimmune diseases. So we always want to know where androgens are at. If a young kid comes in who's just developed type 1 diabetes, whether they're 6 or whether they're 12, you want to measure their testosterone. We are seeing in the Naples Clinic young guys come in at 18 years old with not enough testosterone. And there's a small amount that takes place even before puberty, a small amount. So we're now taking a look at using testosterone in a wide variety of ages. Gender differences in autoimmune disease, a higher incidence of autoimmune diseases in females, though men have more nephropathies. We've already discussed that. This is plastics. There are more assaults on our hormones now. Everywhere we look, and they're all assaulting these wonderful hormones that protect our gut wall. And we've kind of gone over this lately because I've talked about plastics and I've talked about the endocrine disrupting compounds. We don't think of birth control pills as being an endocrine disruptor, but they block all the release of hormones. They block the release of oxytocin. There's replicated papers showing that women who've been on birth control pills longer than a month tend to make poor decisions in relationship choices or relationship solutions. So whenever you're a psychologist and you're working with someone that's on birth control pills, know that their hormones are blocked, including oxytocin. Birth control pills, what was the other comment I wanted to make? And it just slipped out of my brain. I can't think of it right at the moment. And remember that parietal cells are the very first cell. They secrete stomach acid, which then secretes cholecystokinin, which then goes to all the other digestive players and says, food's a coming, gallbladder contract, pancreas starts secreting hormones. So parietal cells are the #1 cell that starts digestion. And they produce estrogen, and that estrogen is supposed to go to the liver to help with detox. We talked about this the first time we had our gift of talking about hormones in the gut. Well, if the parietal cells are exposed to cadmium or metalloestrogens or plastics, they don't produce the same amount of estrogen, and you don't get the same detox. So at every single level, endocrine disruptors are disrupting the protective action of hormones on all these diverse capacities of the gut. And gut illnesses are on the increase, and proton pump inhibitors are one of the #1 selling medications besides statins and antidepressants, because most people's guts don't work well anymore. We mostly think of it as, well, people are eating junk food. We don't really think of it that hormones help rule the healthy gut, and hormones are under assault by an unhealthy, polluted, toxic planet. And now we start putting this together. So you want to help patients reduce endocrine disruptors, maybe just hand them a sheet of potential endocrine disruptors, or turn them to my book, Hormone Deception, which explains everything about endocrine disruptors, what they are. And the last several chapters are a tour of your supermarket cart, your office, and your home. So exactly how to reduce exposure, because that will help keep their hormones healthier and their gut healthier. So I've been trying to champion the understanding that hormones, from thyroid to sex steroid hormones to oxytocin, the love hormone, have a lot to do with the health of the overall gut, and that these very hormones are under assault. But we can use these hormones even in younger ages to help heal specific conditions or protect against operations, surgical interventions, not just use them for aging, perimenopause, postmenopause, andropausal humans. We actually can use, once we learn what the mechanisms of actions are, we can then use these as therapeutic tools in a wider base of patients. Hormone altering chemicals are happening from early on. Boy, I just, there's so much of exposure before the egg and the sperm meet for conception and before the baby is born. And for example, phthalates will disrupt estrogens, and then they won't be able to make adhesive proteins, and you're more prone to leaky gut, which would mean you could be more prone to type 1 diabetes, or more prone to juvenile arthritis, or any of the other growing epidemics of illness. And also, of course, there's a growing epidemic of type 2 diabetes. But infants and toddlers are constantly exposed to toys that have phthalates and bisphenol A. We heard early on in this talk that bisphenol A blocks the release of sex steroid hormones from a variety of tissues. And studies show that there's an average leaching of a fair amount of bisphenol A and phthalates from toys. So you don't want kids to have plastic toys. Now, I don't know what you use for a pacifier. Are there pacifiers that are made of healthy plastics? I worry about pacifiers. I'm not sure if I had a baby right now or grandkids right now, and maybe I'd want them to suck on a piece of cloth, or I'd really be on the sleuth for a healthy non-plastic pacifier. And I've wondered about that, like how many babies are sucking on pacifiers that end up really causing a lot of issues with their gut as they age. It's something to think about. EDCs especially bind with the androgen receptor, and this has been reported associated with diabetes in vitro, animal, and clinical trials. Androgen specificity, this is the title of the article. And we're seeing less and less testosterone in men, and less testosterone in some women, and more testosterone in the growing epidemic of polycystic ovarian syndrome. So hormones can be a little bit all over the place. So here's secretory IgA. Exercise increases it, but it increases it a little bit more in females because they already have less testosterone than men. It's reduced by elevations of cortisol. And here's that one study where chewing gum significantly decreased production time for the second saliva samples by 3 to 6 minutes, and excessive snacking reduces secretory IgA, which is where your immune system, you hear the famous phrase, most of your immune system lives in your gut. That's your secretory IgA. Here's another interesting article that you can read on your own about secretory IgA and how it's greatly affected by testosterone. Androgen receptors need to be just right, not too much, not too little in the gut wall for the gut wall to be working really healthy. The clinical, pathological, and prognostic significance of androgen receptor overexpression in colorectal cancer. So hormones love to be Goldilocks just right. So if you have a young, I now think that hormone levels should be tested in children, in teens, in early 20s, late 20s. There's so many endocrine disruptors and so much more illness. We all need to be looking at hormones in all of our patients. And we can be the doctors that start pioneering that to be. EDCs block the androgen receptor, and we've just seen how important it is for the microbiome. What helps reverse the blocking of endocrine disruptors, especially on the androgen receptor? Resveratrol. Resveratrol reduces the adverse effects of endocrine disruptors on the androgen receptor. Well, that's pretty amazing. This testosterone biome and everything I've been talking about really tonight is not well appreciated by most docs, and they certainly don't appreciate the role that androgens exert such an important effect in the gut. I don't think most gastroenterologists would say, hey, take a little testosterone before you go in for your gastrointestinal surgery. But we could be the docs, and what you would, I think now what we should do is when we have a patient, work with a gastroenterologist, say, here's some of the data, this is why I recommend this, or just go ahead and give the patient it, and then give the patient some of these articles, have them share it with the doc and let the doc see how well the patient does as they go on. So our ill-placed planet is making our hormones ill, which is making our guts ill. And let's see where we are. I think we're almost, let's go to progesterone, I think, because I'm going a little bit over in time. So here's an article about possible explanation. Let me go back here. Go to this. So a possible explanation could be found in the implication of both the androgen receptor and the estrogen receptor. I don't remember the slide now. I'm pulling a blank. In the regulation of serum androgen levels. The above mentioned hypothesis was reinforced by the similar findings who analyzed 2 large cases of colorectal cancer. They further found a greater chance of microsatellite instability or P53 mutated tumors. That's tumors that were due to loss of the protective tumor suppressor gene P53. What is this? I don't remember why I have this slide here. Their concern was the lack of a common accepted parameter term that is not yet established. I don't remember why I have this slide in here. ER beta and androgens. I think this is just a slide to show that androgens and the ER beta or receptor both help maintain health of colonocytes. And when either ER beta or androgens are disrupted, you have more risk of tumors. But this was an article that explained the androgen receptor can work in cohort with the ER beta receptor. Where did we ever hear that before? We don't hear stuff like that. Sorry, I couldn't remember why I had this slide. And I am, how much more do we have here? Because we're going a little bit over. Let me see this. I think we're gonna stop here, and then I'm gonna finish this for one more little round, because I promised Sarah I wouldn't keep her really, really late tonight. And I think we have a bit more to go. And it is presently, we've been over an hour and almost 10 minutes, and I want to take some questions. So we still have part 3 of the gut, but I hope that you like this gift. I wanted to gift you some information, not just our regular 1 time a month meeting, and I hope you like this. So if you particular brand of sustained release, well, it's compounded. So I just have the compounding pharmacy make it. So it's not a brand, it's compounded. And every now and then, if somebody says they're really reactive, I might have them put a little probiotic in there. someone says they're really reactive. And every now and then, I've been having Tahoma Clinic test people's reactivity to hormones and get sublingually desensitized. And just recently, I've started having her test T3. And some patients have been coming up where they're reactive to compounded T3. And now we're recommending desensitization to this. So if a person has had a history of a lot of allergies or a lot of mold, or they just been a complex patient, we are now testing reactivity to hormones before we replace them. And this also includes thyroid, not just sex steroid hormones. And I just had a patient a while ago that she couldn't take progesterone no matter what. And she was a breast cancer patient. And I think progesterone issues are often I think all breast cancer patients now should be tested and desensitized if need be. And this is a new stance that I've taken in the last year. And so we had her tested. She was reactive to progesterone. She had several weeks of progesterone. It's usually 2 weeks of progesterone sublingual drops. Then you get retested again in 5 weeks to see if you're still reactive or whether the 2-week therapy was effective. And now she's been on progesterone for 5 years with no problem. So it's something to consider. So you are saying that just T4 is not enough. I am definitely saying just T4 is not enough. That is exactly right. They have cardiac challenge with liothyronine. Is that what it is? If they have cardiac challenge with, I don't understand that question, Lynn. You have to write it out one more time because I just don't understand what you were asking. Or do you want to ask it?
Sure. With T3,
right?
Supplementation with liothyronine, it's just too much cardiac activity. And so how do you titrate?
It's not too much cardiac activity. I'm not saying that.
Well, no, I'm saying there are palpitations though.
So you have a patient? Are you talking about a specific patient?
Yeah, yes, because there's complaints of it being too reactive. They're getting hypersensitive to it. It makes them anxious.
What was the dose level?
Oh, that's what I don't remember. I'm sorry. Because we stopped it months ago.
Is this one patient or is this a number of patients?
One patient. But you're saying really, my question to you is, how do you test for titration of T3 to find out the perfect dose? You just run that?
I said you start with 5 micrograms and every 3 days you add another 5 micrograms. Well, if they were at like 3.0 and you just felt like they needed a little thyroid, you might just give them 5 micrograms and call it a day. Because 3 to 5 to 4.5 is ideal. So you're not always titrating up. It's just someone that has a really low T3 and lots of hypothyroid symptoms.
Okay, thank you so much.
So in a lot of people, you'd only need to give them one initial dose. And if they do well, just call it a day. But one of the big things of getting someone on the right amount of T3 is they get sustained energy throughout the day. I mean, thyroid besides adrenal has a lot to do with sustained energy throughout the day. So, and if they have, and then you want to look, well, where more of their energy crashes? Are they morning or are they evening? Because then that might tell you where you might, if you want to add the next titration, if you have worse crashes at 3 o'clock and at 7 o'clock, you might want to first start in the morning and then go to the afternoon. If you want to double it up again, then you want to do it more in the afternoon. You kind of go by when they have their crashes. But if they are benefited just by a lot of people do well with 5 micrograms. I'm on 10 micrograms. And boy, when I finally got to, and usually you start out twice a day just to go slowly and creep along or where their symptoms are. But then usually over a few months, you can just give it all in the morning as sustained release. So they don't have that burden of taking it twice a day. Often they can graduate to just once a day. Did I make sense with that?
Patently clear. Thank you. Very helpful.
Okay. But a lot of people do well with just 5 micrograms. But so when I was talking with Kent Holtorf, he was saying that T3 wakes up the heart, and he gives a lot of congestive heart failure patients fairly high doses of T3. He said he had one patient that a colleague of his said was this. I was lecturing in Memphis, Tennessee last April, and he was lecturing there, and he said he had a colleague that had a patient with congestive heart failure that was really kind of dying in the hospital. So he went over to the hospital, he gave him 100 micrograms of T3, and the guy rallied and eventually got out of bed and was fine. And it's interesting. So I've now had about 4 or 5 congestive heart failure patients, because in Naples, I have a lot of older patients, and I make sure that I get them on T3 if their T3 is low, not if their free T3 isn't low. I mean, only if they need it. Boy, has it made a difference with energy and with how it gets rid of shortness of breath. It's amazing when someone needs T3 and you get them on sustained release T3, there often is a very sustained benefit. I used to have energy crashes and other things. I don't have that anymore at all. I got on sustained, and I started out at 5 micrograms, and then I did 5 micrograms in the morning and then before lunch. And then within 2-3 weeks, I just did 10 micrograms in the morning, and I've left it at that. And I'm like strong, 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 just strong, strong. Now that, of course, that's not the only thing that contributes to that, but it is a major player. You'll know you have too much thyroid too, not only if you get a fast heartbeat, but if you start going to the bathroom too much, because it affects transit time so much. If someone starts going to the bathroom and having 8 or 9 or 10 eliminations, then they're on too much thyroid, because thyroid helps contract the gut. What are your thoughts on pendulum akkermansia? I don't know about that. So I'm sorry, but I don't know what that is. Do you find there are no contraindications to eating soy? No, unless you have a soy allergy, but fermented soy, like soy sauce, the fermenting process changes the protein. So a lot of times when people have an allergy to something, they can consume it when the product is fermented, but not always. You always have to try it out. But no, I don't see any reason why someone should not eat soy. This whole phobia of soy makes me very upset. I gave a whole talk here, if you were there, on soy, and I have a whole chapter in Safe Hormones called To Soy or Not to Soy. There's no debate in the literature anymore. There's so much vast literature that soy protects against every hormonally driven cancer in both genders, that when oncologists tell breast cancer patients to avoid soy, I want to grind my teeth to powder. Carol Brinkman says a good esthetician to get rid of those chin hairs. Definitely, and definitely need a good esthetician. That's a good idea. I've tried whatever that is, electrolysis, and it didn't do diddly squat for me, but I guess I didn't do it enough. And then the woman moved away, and you have to have time to go to these places. And so many docs take women off their hormones before their surgery. Yes, that's a good point, Carol. So Pam Smith was talking about how you should take your hormones right up to your surgery because they're so protective and they help you with recovery. There's no doubt about it. And they also take people off things like iodine. What's iodine going to do, right? They take off everything because they don't know what they do. And they're just trying to avoid potential complications and blood thinning. They don't know what supplements thin the blood and what don't. And they don't want the blood to thin, which is to go off fish oil. And so that does, that's what they're trying to do, is avoid having bleeding issues. And so they just say go off everything because they can't sit there and go through all of that with you. So hormones, I think, should be right up to surgery. That's a great comment, Carol. Absolutely great. Amazing gift as usual. Thank you very much, Carol. Oh, thank you, thank you, thank you. How does one test reactivity to T3? Oh, so I use Tahoma Clinic. They have long distance, and we put this into and I think Sarah will now put it in there. We have a link for this to get in contact with Virginia Allen from the Tahoma Clinic, and they have a bowl machine and they do it long distance, or you can use, what's the name of, I have a block against remembering the acronym for that pressure point. What's that process where you can identify allergies and desensitize with that method that the chiropractor designed that's so effective? Why can't I ever remember this name? Dr. Brownstein uses this method to desensitize. He tests all of his hormone patients. It's called NAET. NAET is another way of doing it. And Dr. Brownstein does that in his office. But now Sarah has put this up in the notes. It's Tahoma Clinic Medical Executive Assistant, Virginia Allen. And the number to call is 206-812-9988. And she's just invaluable. They have 2 people at their clinic that do it. I went there myself and had the other person, this genius on the Vol machine, work on me, and I really felt very comfortable with what they do, and it's a great resource. Dr. Maureen Pierce says she uses muscle testing. That's the one thing with muscle testing is you don't desensitize. You can identify, but you don't really, but maybe there's some people, Sarah and I were talking about this, and thank you, Sarah, for all your help tonight and sitting on here. I really appreciate it so much. I'm so much more comfortable lecturing when you're here. I can't tell you. Thank you, thank you, thank you. Some people are artists at muscle testing, and they might be able to desensitize. They might have ways that they've worked out over the years, or I might know of what they know to do to desensitize through muscle testing. So I might not be up on that, but I really I work so well with the Tahoma Clinic. That's what I've been using. Sarah says you're most welcome. Thank you. I can't tell you how much I appreciate you guys. Isn't it amazing that within the compartmentalization of medicine, every single tissue in the body has receptors for hormones, and there's so many ways to clinically use hormones, and there's no way that this is taught anywhere. Thank you. Maureen said, I learned so much from you. Thank you. And then Sarah said, January live webinar is this Thursday. Oh, so this Thursday, I'm going to talk about the importance of stomach acid and how and why you do a really good stomach acid challenge and a pancreatic enzyme challenge. And that's what I'm going to talk about this Thursday. And then I want to take Q&A. There was Sherry Beck had a question, and I'm going to address that. If anyone else will have time for Q&A, so please send in from the live level, not the pro level. Please send in questions for that level. Thank you, Lynn. I appreciate you saying grateful, grateful. And if you have questions, please, thank you, Sarah, for putting that up there. If you have questions, please send them in to members@drlindsayberkson.com. I just love seeing all your faces. I hope you sleep well tonight. And thank you for being here with me tonight. Blessings. Bye-bye.